Dr. Suddha Jayaraman, who will be giving us a talk on the basics of performing exploratory laparotomy. Dr. Suddha Jayaraman is a professor of surgery in the Division of General Surgery and the director of the Center for Global Surgery at the University of Utah. She completed her general surgery residency at the UCSF, during which she obtained a master's degree in public health in developing countries at the London School of Hygiene and Tropical Medicine. She's worked on several projects on trauma epidemiology and trauma systems development in Uganda, and she went on to do a trauma, critical care, and acute care surgery fellowship at the Brigham and Women's Hospital, Harvard Medical School, where she was awarded the Harvard Medical School Health Disparities Fellowship to work on evaluating disparities in injury mortality in Rwanda. She has authored numerous publications on injury in low and middle income countries, and is an author and peer reviewer for the Cochrane Systemic Reviews Injury Group, and a collaborator and co-author of numerous papers on the global burden of disease by the Institute of Health Metrics and Evaluation. Her domestic interests are on medication safety in trauma and critically ill patients. Let's welcome Dr. Suddha Jayaraman.
For trauma for this series of talks. My name is Suddha Jayaraman. I am a trauma surgeon and surgical intensivist at the University of Utah in Salt Lake City, Utah, in the United States of America. I am going to be speaking with you a little bit today on the basics of performing exploratory laparotomy in trauma, especially in austere settings. As a background, I was born and raised in southern India in Bangalore and Chennai as a child, and my family immigrated to the United States when I was about 12 years old, and I've lived in the US ever since. But I've had a very long history of being engaged in various parts of the world, especially in East Africa, where I've had partnerships in Rwanda over the course of the last decade. So thank you for joining me today. In talking about the fundamentals of trauma laparotomy, we need to be aware of what are the goals that we're trying to achieve. The first and most important goal is control of bleeding along with resuscitation, and that's what's necessary to prevent immediate death. I often think of this bucket with many different holes as a good example of what a trauma patient who's been injured is going through. So our goal as a surgical team is to control all of these potential sources of bleeding and ensure that the bucket is being filled up, in our patient's case, with blood. The second goal of a trauma laparotomy is to control contamination, and obviously this is to prevent delayed sepsis and help with nutrition. Time is the most important variable in trauma. Speed is essential, especially to bleeding control. So then the question becomes, how do you maximize speed? And obviously preparation is key, and anticipation of future steps is really important. There are two specific areas I would like you to consider. One is the technical aspect, and the other is non-technical, and we'll start with the non-technical part first. As you know, when we operate, we don't operate alone. We operate in a operating team with anesthesia, nursing, various assistants. Maybe there are trainees as well. And so getting that team to function efficiently and rapidly is really important, is an important part of that speed of the laparotomy. And that requires awareness of non-technical skills. These are also known as human factors. And there are four major areas that are considered to be critical areas that you need to be aware of: communication, situational awareness, leadership, and decision making. A lot of this work has been done by Steve Ewell at Edinburgh, and his website is noted here below. So how do you go about improving that operating room team? So communicating with the anesthesia team to ensure that they can anticipate shock when you open up the patient's abdomen and you have sudden loss of tamponade, the patient may deteriorate suddenly. And so having either pressors or products or both immediately available is important. For the anesthesia team to know that you are struggling with hemorrhage control, and for them to notice that you're going through a lot of towels or laparotomy pads or sponges, and controlling bleeding is essential situational awareness. Your decision-making and anticipating injury patterns and planning to address those injury patterns rapidly is essential. And your ability to communicate and lead the team in thinking about what are the next steps, what injuries are you identifying, what are you expecting, anticipating, and what equipment might you need to address those injuries. That shows communication and leadership. So as you can see, each of these steps it demonstrates the value of those human factors or non-technical skills that you need to have to make sure that your operating team is efficient. Obviously, your own technical operative efficiency is important. And so your ability to rapidly make surgical decisions requires anticipating the injuries. And we'll talk a little bit about how mechanism plays a role here. You also need to think about preparation to address these different injuries effectively and efficiently, and so your technique makes a difference. And then obviously for different types of injuries, there are different possibilities of control, and you need to think about what equipment you need to use. This is a picture from the internet about several different ways of controlling a major liver injury. So you need different tools and techniques for all of those, and you need to be able to anticipate them and prepare for them so that you can do them rapidly. So when you think about how to anticipate injuries, obviously a good place to start is a trauma mechanism. So mechanism affects the types of injuries because a blunt injury, for example, fall from a significant height, whether it's 3 or 4 meters or higher, often leads to solid organ injury on top of potentially spinal cord or brain trauma. Sometimes high-speed car crashes, for example, leads to bowel injuries, such as this one pictured below called a bucket handle injury, where the mesentery is avulsed from the small bowel. Penetrating trauma tends to injure multiple loops of bowel and less commonly, but can be catastrophically affect solid organs and vasculature as well. So you need to think about what are the different equipment that is needed to address a variety of these injuries. In this picture, there is a liver with laparotomy pads above and below it, packing a liver injury. So before you start your laparotomy, you need to get the room ready. You need that preparation and communication. You need to make sure you have a plan for how you're going to handle sharps, which are scalpels and needles, with your assistants. You need to make sure that the staff in the room can help you with counting towels, sponges, and instruments, and that you get cautery, suction, lights, everything optimally set up. You need to make sure that the key equipment that you might anticipate using is available to you. Either it's open on the table or in the room and easily accessible, or outside of the room and readily available. And this is a good time to know what is not available, and because that'll obviously affect what techniques you may use as soon as you open up the patient. Again, these are steps to prepare before you start the operation. So let's talk about the technique of a trauma laparotomy. My technique is to use a 10 blade and in size, generally in an unstable patient, I'm very liberal, and I start at the xiphoid and I extend it all the way down to the symphysis pubis, going around the umbilicus. I quite often incise right down to the fascia and then make a small incision into the fascia. I put the knife down. I put our finger in underneath the fascia, and I either use cautery to open it up on both sides, or I use a Mayo scissors, a heavy scissors, to open up the fascia on both sides, depending on how unstable the patient is and how fast I need to move. I then open up the peritoneum just bluntly with a finger, and separate the peritoneum bluntly. Usually you don't need to use electric cautery to open up the peritoneum. And then take the falciform ligament down first. And I use clamps and ties to take this down. Typically, I do this because when you retract the abdominal wall with a Richardson handheld retractor, it's very easy to avulse the falciform and tear the liver. And I don't want to cause an injury to the liver in an unstable trauma patient. So I start with that first. And then because at that point I am already looking at the liver when I'm taking down the falciform, I pack the right upper quadrant quickly. Sometimes I pack the right upper quadrant and then take the falciform down, depending on how much blood there is and how unstable the patient is. But those are typically performed essentially rapidly and immediately. And I pack the other quadrants, left upper quadrant and bilateral lower quadrants. Typically in a blunt trauma patient, I'll start with the upper quadrants first, since I anticipate that there are probably solid organ injuries. At that point, once I've packed the abdomen, that's usually a good time to wait for the anesthesia team to catch up from the loss of that tamponade. They may need to give pressors, they may need to get blood products. Sometimes this part takes a little while because they need to be able to have the resources to administer to the patient. Once I have a sense of stability of the patient, I then start with evaluating the bowel. I have the bleeding packed away and controlled. I raise the transverse colon, identify the ligament of Treitz, eviscerate the small bowel, and start to assess the small bowel in a back and forth, side to side manner to identify any gross disruptions of the wall of the small bowel, any mesenteric injuries, and ongoing bleeding. And I can control them with clamps as I go along. I don't bother with immediate resection necessarily. I just want to control bleeding and contamination as rapidly as possible. So I run the small bowel from the ligament of Treitz all the way down to the terminal ileum. And typically, again, I look up, talk to the anesthesiologist. How's the patient doing? Okay, great. And now's a good time for me to go ahead and finish in the right lower quadrant, look at the cecum and right colon, and then focus on the upper abdomen, the right upper quadrant. I remove the lap pads and look at the liver, feel the entirety of the liver, feel the back of the diaphragm, and ensure that there's no sign of any injury. And if there is at that point, decide how I want to approach it. And sometimes with a liver injury, as you think about what your next steps are going to be, it's helpful to go ahead and pack it and sandwich the liver between towels or lap pads, and then ask for that chromic stitch if you want to use that or something else. And then I typically turn to the left liver, assess the same thing, and then the spleen. And when I get to the spleen, I'll remove the lap pads if there's an obvious injury to the spleen that I feel on palpation. I medialize the spleen by putting my right hand around the back of the spleen, bringing it up into the midline, and then I use my left hand to control the hilum of the spleen. And then I ask for a large clamp to put across it, and now I have control of the splenic artery and vein. And typically I will either resect the spleen at that point, or and then oversew the clamp, or use a stapler if that's available to take the vessels. Once I've done that, I would usually leave lap pads in the left upper quadrant because I want to know how good the hemostasis is. I'll finish looking at the transverse colon, left colon down to the pelvis, and make sure there's nothing else that is going on. And then I'll open up the lesser sac in the gastrocolic ligament, look at the pancreas, make sure that there's nothing injured in the retroperitoneum. and then go back to the stomach bed to assess if the stomach artery and vein need to be oversewed again. Typically, looking at retroperitoneal injuries along zone 2 laterally, these only need to be explored if they're expanding, which typically is more common in penetrating injuries. And if I identify a central retroperitoneal injury at some point, either when I look in the lesser sac or when I have eviscerated the bowel and I'm looking at the root of the mesentery, then I typically communicate that to the anesthesia nursing team so that they know that there's a major injury and that I may need more equipment and the patient may need more blood products. And this may or may not be survivable. So these are all critical pieces of information that I ensure I communicate to the rest of the team in the room. Obviously, every operation has pitfalls. So let's talk about the non-technical pitfalls. One of the biggest challenges with any procedure that you do is fixating on one problem or one solution. This is really important to be aware of. This is a very normal default setting for all of us as humans. So this is why I have a standardized method of looking at the abdomen, and I try to look at all of the abdomen so that I have a sense of everything that's going on before I work on any one particular problem, just so that I don't get caught up with trying to oversew a liver injury while the spleen is still bleeding, while there's an expanding retroperitoneal hematoma, because that liver may not be the main problem. So ensure that you are thinking about that. Another challenge is not asking for help or additional resources soon enough. Remember, time is critical. So understanding whether you can, whether the extent of injuries requires further assistance. Maybe you need a more experienced assistant. That's an important assessment to make early so that that person can be called and it will take them some time to arrive. Or if there are additional resources that you need, do you need a different retractor? And typically use a valve floor retractor, which is very easy to assemble. Some people like to use a plastic retractor called an Alexis. You can certainly use other things like a Bookwalter or Omni or other retractors that you may have. I try to use the ones with the least amount of parts because they take the least amount of time. So quite often I would just use a Richardson handheld retractor, for example. The third pitfall I want to warn you about is to try to do too many things in this first operation. In general, I try to be done with the operation within 1 hour of entering the operating room because I want to focus on stabilizing the patient. And so at that point, you need to assess whether this is an operation that can be concluded immediately, or if this needs to be a damage control operation, which I'll tell you about shortly. Technical pitfalls are really important to think about. Missing diaphragmatic injuries, especially in penetrating trauma, is a risk. So cautiously and patiently looking at the diaphragm and palpating it is important. A small injury to the right liver, to the right diaphragm above the liver, is not a big deal, but you need to be thinking about where these injuries are and how you're going to fix them. And typically just a running stitch is perfectly fine. I tend to use a monofilament that is semi-absorbable, so something like a PDS, but you can use a Vicryl as well. You may need to use something that's more permanent. So if you have silk or nylon, those may be better options than Vicryl, especially for a larger tear that's on the left side. Other technical pitfalls I mentioned, it's not looking in the lesser sac and missing a pancreatic injury. Obviously, pancreatic injuries can be quite devastating, so it's important, even if everything looks good anteriorly, to not forget to look at the posterior wall of the stomach and the pancreas. Lastly, Conservative management of trauma is something that means different things in different places. It really depends on the resources. And I encourage you more to think about it as operative versus non-operative management, and to identify which is appropriate for your patient and for your institution and the resources that you have. In some settings, not operating may actually be a luxury. Do you have the ability to put somebody in an ICU bed and monitor them with labs every 4 hours and count on being called and having an operating room ready if they deteriorate? That may be a luxury, and it may be a risk to count on that in certain settings. So do you have the resources for operating versus not operating? And so that's an important question to be aware of. I'll tell you a little bit about damage control, as I mentioned it earlier. This can be a luxury depending on the resource availability of your institution, but it's a valuable tool to have in your toolkit. First of all, if you plan to do damage control, you need to have a plan for who and how and when that second look operation is going to occur. And so you need to think about what those steps involve. And again, this is part of that anticipation of next steps. If you have the availability of resources to perform a damage control operation, leaving somebody's abdomen open for resuscitation can be easily done. Here's one technique. This is actually a technique that my colleagues and I use commonly. Place a plastic sheet that goes all the way down to the pericardial gutters. And the sheet has small holes in it, and it's just a sterile plastic sheet, and it covers the bowel. And then we place a towel on top of it that again goes down to the gutters so that it pulls up the fluid that collects in the gutters in a capillary action to draw them to drains that you'll place on top of this towel. Typically, there's another towel so that the drains themselves are not occluded by a sticky drape, which then goes on top of that second towel to then secure the towels and the drains to the skin. You can use other techniques such as suturing only the skin closed and leaving the fascia open. The risk with that is a concern for abdominal compartment syndrome, which is why we're leaving patients' abdomens open after a major trauma operation. So suturing alone is not a great option, but if that's the only option that you have available, as long as you have a plan for that second look that can be accomplished rapidly, that's a reasonable next step. Using a negative pressure vac as pictured here is also a common and reasonable thing to do. The biggest challenge is cost. Lastly, laparoscopy for trauma is an important but controversial tool in your toolkit because this depends on the right patient and the surgeon's experience and judgment and the availability of resources. Typically I tend to use it in penetrating cases where it's not clear if the peritoneal cavity has been violated. There's no obvious momentum that is protruding from the injury. And the patient's too agitated for me to even assess the wound. I don't perform a wound exploration. I think the likelihood of it missing a potential intra-abdominal injury is too high. And in my setting, that is okay because I can take them to the operating room to do a diagnostic laparoscopy in those cases. The challenge, of course, is equipment availability, the stability or instability of the patient, and their ability to tolerate insufflation. And then, of course, the limitations of a diagnostic laparoscopy means that you can't assess retroperitoneal injuries very clearly. So those are some things to think about trauma laparotomy. I hope you found this session to be useful. I now look forward to a discussion. So thank you so much, Dr. Amila and the esteemed colleagues at the Asian Collaboration.
And we have Dr. Suddha here with us. Would you like to make a few comments before I invite our reactor, Dr. Osaree, to say a few words?
Thank you so much. I appreciate the opportunity to be here. Thank you, Dr. Orlando, and colleagues who are involved in the chat.
I think there are lots of great questions that are coming up. There's no one right answer. I think the key thing to remember is what are the goals of the operation and are you able to achieve them in a rapid period of time in an organized manner? And that's what surgical judgment and practice of surgery is all about. So I really am enjoying the chat discussion. So please feel free to ask more questions and I look forward to the reaction. Thank you.
Thank you, Dr. Suddha. Very nice and enlightening talk. Maybe I will go on. We can take in more questions and further discussions at the open forum at the end of all the talks. I'd like to welcome our next, our reactor to Dr. Suddha's talk, Dr. Osaree. Dr. Osaree Akaraborworn is Associate Professor, Division of Trauma and Critical Care, General Surgery of Songkla Nagarin Hospital, Prince of Songkla University, Thailand. She is a member of the Committee on Trauma, Royal College of Surgeons of Thailand, and the Thai Society of Critical Care Medicine. She's also certified instructor on various training courses like the ATLS, DSTC, ACLS, BHTLS, and WinFocus. She has written multiple publications and various academic presentations internationally on topics related to, but not limited to, trauma and acute care surgery. Let us welcome Dr. Osaree.
Hi. Thank you, Dr. Thiel, for the introduction, and thank you, Dr. Suddha, for a very impressive talk. Actually, the talk already covered everything that it needs to be done for trauma laparotomy. Just only a few points that I would like to share from my experience. First of all, I think non-technical skill is the most important thing in the critical period, which Dr. Suddha already covered in her talk. The preparation is the next things that make the operation smooth. In my opinion, I always prepare for the worst case scenario. Even if the second operation for remove the packing, I always prep and def from the neck to knee in order to, if the bad thing happen, I can do the resuscitative thoracotomy. And another thing for the preparation, if I have the case that that I think that the patients have high chance to need the angioembolization, such as the abdominal injury plus bad pelvic fractures. If it's possible, I try to do the operation on the hybrid OR because after I do the operation, I don't need to move the patient from one place to another place. And from the pitfall, I completely agree with Dr. Suddha that a lot of missed diaphragmatic injury for the penetrating trauma. So in my experience, I try to visualize the diaphragm in case on the penetrating injury because I think it can, with that, it can be sure that it's no missed injury, like a pass from the hand feel and then do direct visualization. And decision making is the most important thing for the bleeding patient. I try to packing before the patient turn to coagulopathy. Because if the patient already coagulopathic, packing might not be useful. So decision to packing need to make early. And the last thing is, I don't know if you have the same problem with me. If I try to packing the left lobe of the liver or like entry of the liver, normally in the temporary abdominal closure, I do open the fascia and close the abdomen with the plastic sheet. But when I need to pack the left lobe of the liver, it's hard to make the packing place at the liver. So I need to do the suture of the upper part of the abdomen of the fascia to make my packing in place. Otherwise, it's hard to pack.